Welcome everybody to the AOMP webcast, where we are inviting experts in the field of physical therapy to come and talk with us about a variety of topics. Today we have a very special guest. We've got Dr. Chad Cook with us from Duke University. Most of you know who Chad is, probably the most prolific researcher and lecturer, one of the people that's had the most influence over our profession really in the last decade. And Chad, it's so wonderful to have you here today. I can't express enough how much fun it is to talk to you. I've heard you lecture and present probably 20 times and at different conferences and stuff like that. And I'm just really excited to share this topic today with everybody on outcomes, talking specifically about outcomes research. But before we do that, I just want a little bit of a background. Your involvement with AOMP over the years, you've been at the conferences year after year, and I know you were on the board for quite some time, and you said you were the treasurer. Talk a little bit about your involvement in AOMP. Why did you want to get involved and stay involved over the years?
Yeah, AOMP, I love AOMP. And I mean, if I had to rank order it, probably the conferences are so awesome that you want to get involved just for the reason of the conferences. But I think it's the people. It is the most unpretentious group that really cares about the profession and cares about people within the profession. Everybody is just so open, and the mentors that I've had through AOMP and just the amount of service that goes on where people in service that no one ever sees. I just think they're the best of our profession, and being around that is why I like to hang with AOMP.
Awesome.
Well, that is awesome. That brings a smile to all of our faces, because I think we can all relate to that and the impact AOMP has had for us. So let's just jump right in with some questions. So let's talk about measuring patient outcomes. I know this is a loaded question and a passion of yours. So could you tell me about your background on outcomes, Chad?
Yeah, sure. I think like everybody else, I started as a clinician, and I was probably skeptical when they first started really pushing these at us in the 90s. I really questioned whether or not this a few questions was actually going to measure the complexity of change and the complexity of our patient's condition. And when I finished my PhD work, I started actually doing a lot of outcomes research. The first type of work I did was cross-cultural validation. And then I got into item response theory, which is a different form of validity. I've done classical test theory. I've created 4 different outcomes measures. So I've been deep in the thick of it for many, many years. I probably have about 40 publications on outcomes measures and looking at validating a lot of the common tools that we use, even legacy measures like the Oswestry Disability Index. Mm-hmm. So I've been at it as a clinician, but also as a researcher. I've got a pretty strong background in it.
How has that evolved? So where are we now? What are you recommending people to use now as far as different outcome measures in clinical practice?
Yeah, that's a superb question. At a minimum, you need at least one. And usually it's a legacy measure. I think a lot of people will use an ODI or an NDI or a pain measure or something of that nature. You're seeing an evolution toward, I think, more sophisticated instruments that have stronger item validity, like the PROMIS tool, something that is shorter but is theoretically captures more of a multidimensional aspect of recovery. I think at every body part region, we probably can name off our top 1, 2, or 3 legacy measures that fit that particular region. At a minimum, I would recommend 1 measure to use, but in reality, we need, I think, multiple measures to really reflect the complexity of our patient's condition.
And are you still looking at it from the context of like the ICF, and I want something that measures at the activity level or participation level, and then something else perhaps at the impairment level? And then are you coupling self-report with physical performance measures? How are you handling that?
Yeah, and a smart person does that because in reality, the change that you see with your patient, that recovery process, it's going to reflect all of those domains. And you brought up physical performance measures and self-report measures. What you see between those two is often so drastically different. Pain and psychological measures markedly influence self-report measures, but they don't influence physical performance measures as much. So I definitely would recommend that if you're looking at somebody and you really want a complex presentation of that individual and whether they've improved, a battery of self-report measures, a core set of measures, and then also physical performance measures. Especially in a sporting population, I think the physical performance measures tell a really important story.
So what would you tell like our everyday clinician when you're thinking about like outcomes you mentioned are just a proxy measure? We are measuring a complex individual, right? A complex phenomenon. What would you tell them to do?
Yeah, I would tell them a lot of different things. I think one of the first things that I would say is these are a necessity. This is part of our patient engagement. You need to read the outcomes measures because a lot of the information that you receive from reading that, what the patient has reported, can be built into that treatment process and that relationship that you build with the patient. But also know that they don't tell the whole story, that there are going to be elements to that patient's recovery process that are not going to be captured from a pen and paper test or from a HOP test or something of that nature. In fact, when we deal with sociological or psychological measures or any form of biopsychosocial measure that doesn't involve a blood test or an X-ray or laboratory value, I mean, at best, our tools are going to capture maybe 50% of the reason or where that person is in their outcome. I mean, there's so much air that's burned into that. So no matter what they do, and even if they use the best tests, they're not going to capture the whole variation on what's going on with that patient.
So I think some people are kind of over the legacy measures or think that we should be moving past that. But you're saying there is still some value, even though you're only capturing perhaps one aspect of recovery for that patient. I guess, what do you think then? What's the solution long term? Where are we going next with this as far as improving the ability to capture more of that recovery process?
So I think the next step is probably a core set of measures for all the body part regions. And right now we're in this outcomes paradox where we try to use the least amount of pen and paper tests to capture the most complex thing you can possibly capture, which is recovery. And then in this paradox, we don't fully capture the things that are really important to that patient. And you end up using, for example, a legacy measure that won't show a bit of difference between two groups, even though the patients will tell you, yeah, this has been a meaningful experience for me. I feel that I have changed. I feel that I have improved. Can I give you an example of one?
Yeah.
We published a paper in 2016 in which we used legacy pain measures, a legacy oswestry measure, and a global rating of change. And you probably know a global rating of change is a person's perceived well-being and where they are. And we randomized people into two groups. One group received what was essentially a placebo manual therapy of just bouncing on their back at L4 and L5. And the other group actually received a very specific manual therapy approach to the comparable region of the patient. We communicated with the patient during that process, etc. We tracked outcomes at 6 weeks and 6 months. No difference in pain, no difference in oswestry, significant difference in global rating of change. The person that got the specific outcome measure said, oh yeah, I'm way, way better, in comparison to the previous group, or to the comparison group who didn't experience a major change, even though their oswestry is improved. So what it tells us is we have these different constructs in our outcomes measures that are influenced by different things, and pain and disability are significantly influenced by things such as social determinants of health and just the general health of the patient. And those things just completely swamp that outcome to the point where you often don't see differences between groups.
So something like a grok maybe is more susceptible to being influenced by the experience that patient has in the clinic when we talk about non-specific effects and all these other extraneous variables?
Yeah, I mean, that's what our study found, but other studies have found the same thing too. And in fact, I just read a paper yesterday where the authors of the paper were really warning researchers and clinicians that if you assume that these outcomes measures actually measure the same construct, then you're making a big mistake. That in reality, they measure with these subtle differences to provide a broader context of that person's recovery cycle, because recovery is also going to be markedly different from person to person because there's so much built in what's important for that particular patient.
Right.
That's really interesting because the GROC is so simple, right? But it sounds like it's measuring a really big domain. I use it a lot in the clinic, but it's interesting to hear that is more supported in the research than like the
Lindsay,
ODI and.
Well, I mean, the ODI is pretty strong. We just finished an ODI validation, and we included almost 57,000 people in the study. And
Wow.
what we did is we actually evaluated each item of the ODI long-term toward downstream disability, toward 30-day rehospitalization, toward a number of proxy measures, decreased mobility. And the ODI does a really good job of predictive validity. It has pretty good concurrent validity. In fact, it has, if you look at the Cosman criteria, you can check the box in most cases with the ODI. The problem with the ODI is that if a person has other health factors such as COPD or diabetes or something like that, you're going to see changes on the ODI that are related to that are not going to be related to the back. So it's pretty heavily influenced by a lot of the other things that are going on. You know, there's another measure that is also pretty simple that does pretty well as far as capturing the patient's perceived element of the recovery, and that's the PASS, the patient acceptable symptom state. And it's essentially asking the patient, is your current state that you're in acceptable to you? And the patient will either say yes or no. And you know, those are valuable things to capture too.
Yeah, that's great. Thank you for sharing that. So when we think about the effect of manual therapy, and there's some inconsistencies in the literature about its effect, do you think that has to do with our outcome measures and how we're looking at that data?
Yeah, I think it has both. And I think if you ever see a large effect in manual therapy in the literature that it's influencing legacy measures, then I would question the validity of that study. Because, I mean, consistently, manual therapy is not going to have marked changes on a person's health status, right? I mean, a health status measure tends to be influenced by the person's general overall health, and manual therapy doesn't really influence that much. So if you see huge effect size differences between two groups, that's questionable right away. That's probably a study problem. But on the other hand, should we expect manual therapy to have huge effects on health status? And you know, I'm a manual therapist. I have been for 25 years, but I think that's asking too much. Whether you give somebody provide a manipulation and maybe treat them for over 3 to 5 visits with manual therapy before you progress to something else, it is probably not going to have a really large effect size in comparison to another intervention. It's probably a nice segue to a more active approach, but I don't think it's designed for that intervention-wise. And by the way, almost all our interventions aren't designed for that. If you looked at, especially low back pain, dealing with chronic populations, there's nothing that provides a large effect size. Cognitive behavioral therapy, exercise, nothing. So it's not a knock on manual therapy. It's just, I think part of that, to get back to your original question, part of that is how we're measuring it. And if you're measuring it with the health status measure, which has a very large encompassing encompassing umbrella, you're not going to see a massive change in those individuals.
And that gives more evidence to what you said about the importance of combining different measurements, because we're more effective when we combine intervention, right? When we combine the biopsychosocial approach with exercise, with manual therapy versus just one of those modalities. Do you
Lindsay,
think
I think it is.
Yeah.
And, you know, I'm not trying to be a homer, because somebody's going to listen to this, say, oh, he's just trying to justify manual therapy. And that's not the case at all. I just think that if we're going to say something has value or not, we need to measure it the right way. And sometimes manual therapy is the thing that is the segue to get person to that next level. But sometimes exercise is also that thing, or sometimes, and that depends on the person.
Mm.
You know, I got asked the other day on a podcast about telehealth. I said, you know, how is telehealth going to be effective if you can't touch your patient? And I said, well, it depends on your patient, because there are a lot of be able to move to that next level, to be able to progress in their overall health or to maintain their health. So, and it's the same with manual therapy. I think we get a self-select population that comes to us that's also looking for that. Their expectations are that this is the thing that's going to help them. And for them, that's the thing that helps.
Yeah.
You mentioned effect sizes. I think as clinicians, we look at effect sizes when we're trying to compare interventions and looking at treatment benefit. But MCID is the other, I guess, kind of thing that people would cite as well. Oftentimes is that, you know, what change does that intervention? What changes does occur as far as how much the change score compares to MCID? But MCID is a very challenging thing to. I mean, you've got 10 different MCIDs for one measure, right? There's just so many variabilities. So what's the solution there?
Yeah, so, I mean, little story first. Lexi Wright, who's also a fellow with AOMP, I remember when she was doing her PhD work, one of the papers she wrote was on the MCID, and I remember calling me up and saying, this thing is a joke. And she goes, and at the time there were 9 different ways to calculate an MCID. And she goes, do you realize there are like 6 different ODI MCIDs in the literature? And they're often extremely wide and different. And they tend to be different for different populations. They're different for different disability levels with the same instrument. So I get it. I know why we've identified an MCID. It's supposed to be easier for the clinician to know what a meaningful cut point is. There's a distribution method. There's an anchor method. And in both cases, they essentially look at group means and what's meaningful based on group means. And I'm a believer that sometimes you can't determine what's meaningful for an individual patient if you're looking at group means to be able to do that. So, you know, I've heard my colleague from New Zealand, Dave Baxter, say that the MCID is a dark art, and I do think it is. Not a big fan of it. Not a fan of using that in modeling to identify responders and non-responders. I think I get it, I know why we have it, but I think we need to be very careful about it. I had a PT student who, her name was Julie Swin. She was an accountant, so she was really good with numbers. And she said, hey, can I use some data from your research study to calculate clinical prediction rules based on the different MCIDs on the ODI, and to see if it brings up different clinical prediction rules? And I said, oh, I'd love that. Go ahead. And she found different clinical prediction rules for each different MCID. I mean, talk about a lack of stability. It's a mess. Yeah.
What
I ask you a question about, what do you tell your students then that are, you know, we're having them learn MCID to look at functional change? What would you say to our, you know, our student SIG that our listeners are from the AOMP student SIG? What would you say to them, how they should look at it early in their career?
Yeah, I would say that it's a starting point. But in reality, that particular patient that's sitting in front of you, that particular MCID or that threshold may not be meaningful to them, and that you need to look at a bigger picture beyond just a clinically meaningful difference. You know, there are really nice qualitative studies, and I'm not supposed to talk about this, but I just reviewed one for a particular journal, and they really did a nice job because they actually asked the patients, is this meaningful for you? And then looked at the values so that it was both qualitative and quantitative. And then they actually did thematic coding to identify all of the very meaningful domains of recovery. And in many cases, those domains are not represented by most of our legacy measures. So it was a nice paper, accepted.
Thanks for sharing that. So I guess that brings us to talk about the legacy measures and what would you recommend outside of them at this point?
I think Eric mentioned earlier, physical performance measures, I would definitely include those. I think they are very telling, and they're also, in many cases, I mean, telling a person who has low back pain that they lack endurance and strength often doesn't resonate until you actually test them and show them. So physical performance measures, I think, would certainly be one. I mentioned the PASS earlier. Yeah. I think one of your board members, and I don't know why he keeps getting elected, but his name's Derek Cluley. Derek's PhD work was on health-seeking behavior. And to me, there's no stronger measure of whether a person feels they've recovered or not is when they stop seeking care. So if they say, you know, I'm at a place now that I don't think I need your care. I don't think I need to keep going to the physician for this. I don't need to keep taking medication. And Dan Ron, I think, is also a board member. We've evaluated that in the military, health-seeking behavior and predictors associated with that. I think that's a pretty good measure. It's hard to do because it's after the fact. But if there was a way to get threshold measurements from some of your proxy measures that are related to health-seeking behavior, I think that is a pretty logical next step.
Okay.
Well, if you had the ability to completely change our healthcare system, just revamp the whole thing, what would you do as far as, like, because reimbursement in a lot of ways is I mean, people are pushing reimbursement tied to outcomes. Would you do that? I mean, is that a good direction do you think to go, considering all the potential issues we have with measures?
So I'm going to say hell no. And the reason why is because that's a huge mistake, because you're assuming this is, and by the way, you can't compare clinic to clinic. You can't compare clinician to clinician because it all depends on the patient. So, I mean, some of the, first of all, Nadine Foster is a stellar researcher, but I've loved her quotes from the past where she said, if you really want to predict what your outcome is going to be, then look at your patient at baseline, because that patient predicts that patient's outcome. And if you're in a clinic full of work comp, if you're in a clinic full of super unhealthy individuals where a lot of their other health conditions are swamping their ability to recover, you're going to look like a lousy clinician compared to that person who sees a lot of young, acutely injured individuals who see rapid changes in a short period of time. There's a guy out of University of Sydney that actually looked, and for example, low back pain. He identified 5 different trajectories of low back pain that basically it's almost like 5 different pain phenotypes over time that person can go. What if you get that chronic pain phenotype, and that's your primary population that you see? And we don't have patients randomized to our clinic so that we get this equal distribution of patient types. What we get are people that are dependent upon the zip code, the social determinants of health in that area, and so I would not do that. But to get to your original question, what would I do if I had complete control? This is going to anger my Republican friends. I'd go universal health care. I've actually read the numbers. It's smart.
Yeah.
Not the Bernie version, but the smart version of universal health care, where everybody's
for president.
No.
We'll start a campaign now.
Skin in the game. I just think it's I mean, right now, I think we see the problems of things going right. It's a perfect time for that.
Yeah, we're learning a lot from this experience.
Yes,
What
we are.
about, I want to change gears a little bit for a second, talk in the world of education, because your Sarah Soley lecture I thought was just, it was an awesome lecture. And you talked a lot about what you just said, reminded me of it. You said your board pass rate for your PT school graduates is not necessarily a reflection on the program, it's a reflection on the students that you got admitted to the program. They're good, you admitted good test takers, and then they went and passed the boards. And that was just awesome. And you talked about other ways that PT schools can kind of measure and look at success, looking at what the alumni go on to do and stuff like that. Where are you now with assessment and measures in education? You talked in that lecture too about grit and emotional intelligence. And I just wonder, because that was a couple years ago, where you kind of are now with all that.
Yeah, so we're capturing all that data, and we actually published the first round on it, and Marcus Roll was the lead author in the study, but we created a scale out of other scales. And first of all, thanks for saying the kind words about that. That's a good memory you have. And but yeah, that was a great experience. I really enjoyed that. But we have looked at different scales. I mean, things like uncertainty avoidance. You can't be in PT school if you can't take a little gray and a little uncertainty. So those people that are black and white, we try to weed them out. Problem with a lot of the self-report measures for social and emotional intelligence is people game them. I mean, they like grit is the easiest measure to game, and you end up with all sixes across the board. So what we did is I worked with a guy named Corey Simon, and we went through all the items, and we tackled those items in the middle, captured those, and then threw out all of the fringe items that we knew people could game. And then we ended up with a more challenging scale to capture that information. But here's the first round of data, and I don't want to spoil what Marcus Roll is doing. He's working with a group of students on this. But what's interesting is it's not a total score that we're noticing that seems to be related to people that are having academic difficulty. It's individuals that are on the extremes, whether they have extreme grit or no grit, but not in the middle. In the middle, that's fine. So it's the extreme measures that are the ones that tend to be problematic that we're noticing in our student populations.
That's interesting.
We're not sure why.
That's really interesting. Are you guys looking at that prior to admissions? Like, I know we do grit at South College, but it's after they've been admitted. So I think how interesting if we did it beforehand.
We do it beforehand, and then we actually track them and then look at the data and how it actually is related. We have found a number of other findings that are related to academic challenges, academic difficulty while matriculated into the program. And these include, and we found these in previous studies too, the older student is more challenged than the younger student, which is, everybody thought it was flipped before, but it's actually and I don't know if it's just getting back into the mode of being a professional student or whatever, but the older student is more challenged. We have noticed that the institution that a person attends does seem to make a difference. And I'm a believer that you're a product of your mentorship and your experience, your exposure. So, and we know there are variations that some undergraduate institutions surround you with excellence and expose you to really high levels. And that seems to make a difference as a person matriculates.
That always comes to my mind about outcomes, Dr. Cook. How do you think that a person's their emotional and sort of psychosocial attitude or approach at a particular time when they're filling out the outcome plays into it? And I'll give you an example. Like, sometimes I'm given surveys to fill out, and I'm just like angry at something completely unrelated, and so I feel like it influences how I fill it out. And sometimes, I'm in a great mood, And I just wonder if when patients are filling things out, they're in a mood, how many times have you just gone through and you're just like checking boxes because you're like, I don't want to fill this out. And so how much thought goes into really giving good feedback about this? And I've just wondered if you took like really happy people, somebody just won the lottery and you asked them to fill out an outcome measure, how's their back doing, versus someone that just found out, that a loved one died. How would that influence their perception of how they're filling these things out?
Yeah, I mean, I'm with you, Dan, and I know you're asking me a question you already know the answer to. I mean, the studies do show that the psychological state of the individual actually markedly influences their disability and pain scores. So and for self-report measures, and one of the things we talked about earlier was the physical report measures actually help distill that off so that you don't get such a heavy psychological overlay. A guy named Charlie Sheets and I actually looked at the stability of measures over repeated attempts, and we actually found that they fluctuated markedly. So if you had the ability 3 times a week to capture outcomes, you're going to see variations in those legacy measures, and that can't just be related to their physical situation. It either has to be related to the error of the instrument or that state of that individual at the time that they actually complete that particular tool. So I mean, I'm with you. I think that has a huge effect. And we also talked earlier about that any sociological, and I know you know this too because you're knee deep in this, any psychological measure of a person's state, whether it's their behavioral state or their psychological state, at best, you're going to capture maybe 50% of the variance of why that particular thing occurs. And then if you're really good in most acceptable, if your R square or your Nagelkerk is 0.1, then in that behavioral or psychological or sociological model, you've actually done a pretty good job of predicting what's going on in that given situation. And so there's so much error in these things and so much a lack of discrimination between those items that you actually use.
So it's kind of like the reason why we do these 5-day blood pressure checks, because we know that like 1 day is not enough to be really represent what's going on. Maybe you're having a really bad morning, a really good morning, but if you come in 5 days in a row and get your blood pressure taken and that's consistent, then we can say, okay, you've got high blood pressure or low blood pressure or whatnot. So you mentioned physical function, measuring physical function, but a lot of times when we have physical function, it's a self-report of physical function. And so it's the person's perception of how they think that they could physically perform something, but it isn't really an assessment of their physical function. And how well do you think that those correlate? Do you think that, I don't know, if you can take a physical actual measure, is that better? I don't know. What are your thoughts on that?
Yeah, so we talked a little bit about that as well, and we said that if you're going to capture the full spectrum of a person's situation, it's got to be self-report, but you also have to have the physical performance measures. I even think there's a third leg on that now with the wearables that we see, and I know that science isn't perfect, and I don't pretend to be a wearable expert. I wrote 1 grant on it, so I learned a little bit about wearables, and it does seem to really capture something distinctive, because in many cases a person may have the ability in their physical performance measure, but they're not actually active. They don't actually do anything. And then the wearable piece actually relates to the self-report piece more, because they tend to their actions tend to reflect what they think. So I think you need a battery of we talked a little bit about core measures. I think you need a battery of a full core set of measures to get a better perspective of that patient.
Yeah, it's like when you ask me what my weight is and I tell you, I'm like, so sure. And then I go weigh myself and I'm like, what? I'm like 10 pounds off. I'm like way heavier than I thought I was. I think people think they can do things. Well, the study that comes to mind actually published in JOSPT was really interesting, where they put these hidden sensors in these boots of patients post-operatively, I think after a knee surgery, and then they asked them how active they were and how compliant they were, and the data that measured on the activity trackers was like way less than what they reported that they were how they were being active. So their recall of their activity levels and what they were doing was actually much higher than what they actually were doing. So that's really interesting.
Yep.
Okay, one other question. So I've always wanted to run this trial. What do you think the outcomes would be? Where you have one group that comes in, let's say with back pain, and you've got like milk and cookies, maybe, I don't know, free beer, whatever it is. Everyone's like super nice, telling jokes. There's, you know, it's just fantastic. But then you just ultrasound their back and you give them all like inert, you give them all this low value care. And then you have another group that comes in and, you know, everyone's just really short with them, you know, but you give them evidence-based treatment. I guess some people could say that therapeutic alliance is evidence-based, and so you're not building it that way. But anyways, for the point here, you just come in, you're kind of rude with them, and but you're giving them interventions that are based on, you know, the best evidence that we have. What do you think the outcomes are going to be, and why?
So I think the outcomes would probably be the same, and because of the non-specific effects of how you treat somebody and how they feel in a given situation, and knowing how powerful often the non-specific effects versus the specific effects that we see, and then also knowing, Dan, and you know this, that natural history is going to swamp so much of this over time. And if you use a measure such as an ODI or quality of life or whatever that is so influenced by these other factors, these other health factors, finding a difference between those two groups is probably going to be a challenge. So, and I used to work with this clinician named Nancy, and I mean, it didn't matter. And I had just got out of school. I thought, you know, this was in the early 90s. And Nancy would have everybody, it didn't matter if you had an ankle sprain, whiplash, you got the same exercises. And you got a massage. And her outcomes were great. But everybody loved Nancy. They'd bring her cookies and everything. And here we are trying to do all the stuff that you should be doing, and our outcomes weren't any different. So I think it's the non-specific factors in that example you provided.
Wow. We need a little meme for Chad Cook. Cookies and milk for back pain. It's the way to go.
Love and massage. Yeah.
Yeah, no, that's really interesting. Well, I mean, you know, you don't think through these. I mean, you've had a lifetime of experience, you know, exploring and learning all this stuff. It's just fascinating to see the wealth of knowledge, you know, that you're able to bring back to this and realize that it is, it's a lot broader and maybe deeper of a problem. But you know, maybe you guys already touched on this, but when you say that someone getting milk and cookies is going to do the same as someone getting evidence-based treatment, potentially, like what, and for all those reasons that are valid, you know, that may be the case, but then how does like a therapist that's out there, a brand new therapist just graduated trying to make sense of all this, like what do they do with that information? What are your recommendations for, if it doesn't really matter, what do I focus on? What do I do?
Yeah, I mean, that's a great question. I think, first of all, I want to take a step back. I do think it matters. I don't think your outcomes are going to be different, but I do think it matters. And I think it's partially matters because of some of the downstream effects that can come from that. So if we do dependent care, non-evidence-based care with our individual, it's highly likely we're going to get that boomerang patient that's going to come back for every subsequent problem. It's highly likely that person is going to pursue more healthcare, health seek elsewhere, that sort of thing, even though you were nice to them and their, you know, outcomes were the same as the other group that maybe consisted of more self-care related items or strengthening or anything that maybe reduces recurrence rates or where they received education from that clinician where they learned how to cope with their particular problem, that they can manage it themselves, where they increase their self-efficacy. I think often we don't track people long-term enough to see if it makes a difference. I think what our short-term measures that are, you know, they're big nets where a lot of stuff falls through that you can't really capture. I don't think we're able to really tell the difference with that.
Well, here's another question. So I think you wrote a nice editorial on this once on how we do a lot of short-term outcome studies. Like we need to move beyond the 24 hours, the 48 hours. So almost anything's going to work if you measure the outcomes short-term. But at the same time, it seems like when you do a study and you follow people for too long, you get this you sort of get this pushback that, like, how can you reasonably expect that that this outcome would still be making a difference a year, 2 years down the road? So you get penalized for your outcomes being too short, and then you get penalized for the outcomes being too long. So what do you think is that that nice sweet spot where you can, you're measuring long enough, but you're not measuring too long, or inferring for too long that somehow what you did had something to do with that outcome?
Yeah, Dan, I agree with you, by the way. I think, these quick changes that we see in our patient, we expect that to make a difference in 2 years or 6 months or whatever. I wrote that paper, Immediate Effects, Much Ado About Nothing.
Mm-hmm.
You probably also have read some of my work where I'm a big fan of between session effects. So if you see a change on that first day, don't just stop there, measure that and say, success. The key is a carryover change. If you can get that graduated change that carries over, that actually is a pretty strong predictor of a medium-term 6 months outcome for that particular patient. So, and my emphasis in that editorial was, don't just stop with that first visit. That doesn't really mean much, because, like you said, everything can cause a short time. Moving your jaw a certain way can decrease leg pain. I mean, it's just anything can do that. But if you came in the next visit and you see consistency with that across the population, then maybe you're onto something, in which those short to immediate term changes can actually predict longer term changes. And I do think that's important. And by the way, I want to throw support toward that. It's just not in our population. And I know Ali Garcia, we've worked together. She's my postdoc. She completed a paper where we looked at early changes after surgery for patients who receive lumbar surgery. And the same thing that we see in our manual therapy population, where if you see early changes that tend to carry over for a short period of time, it predicts longer term change. We see that for surgery too, for 1 year and 2 year. Almost 6 times odds ratio if you see about a 35% change in a patient after surgery of pain.
Yeah, I think I saw a paper from Sean Rendell. Didn't he do something similar on that just earlier this year?
3 month changes, yeah.
Yeah, I thought that was really interesting. So, man, that's good stuff. A lot to think about. So I read a paper, you're probably familiar with this, a couple years ago that I thought was really interesting, where they showed that most studies, the mean change that you see reported in most studies, that hardly any of the patients actually have that mean change. You have a lot of people that are big responders and a lot of people that are poor responders, but when they looked, like nobody actually had the mean change, and yet we look at that mean change at the individual level. We expect to see that with our patients, because this study said I should expect a mean change, even though nobody in that study actually had that mean change. And so, what are your thoughts on that, and how we should be using the results from outcomes to align with the expectations that we should be seeing with our patients?
I think the way that you code something too will make a difference, especially, almost all the studies we compare the one mean versus the other mean, the mean and the standard deviation versus the mean and the standard deviation. And we just finished a trial where we looked at steroid versus a proprietary injection to the knee. And there was no difference, repeated measures, GLM over time, when we looked at the means comparisons. But when we coded the groups as either improved or maintained, and this is OA of the knee, versus declined over time, there was a remarkable difference between the two groups. Significant difference across every outcome measure we looked at, all the KOOS measures, all the other measures, all the self-report measures, the Tegner, and all we did was change the way we coded it. So I think in many cases, to get to Dan's point, the way you look at it, if you get away from the mean and you start looking at maybe the extreme points, you might find a very different picture overall.
Yeah, it's interesting. We have to relook at, I know we just take a lot of these statistical approaches and what we've done for granted, kind of for granted. And I think as time evolves, there's newer and newer models and newer ways to look at things. And the things that we just sort of assume as this is the right way to do things, it never provides a full exact picture. It's just, this is the best approach. We're trying to analyze and capture the essence of something, but it's still a model that isn't perfect, and there's still a lot that's missing there. And so that's really interesting. I think you and I have been looking at this a lot, and I think there's a lot of interest in this as well, and is knowing who, well, obviously we all want to know who. It'd be great if someone walked in and we could know whether they're getting better or they're getting, they're going to get better or they're going to get worse. Like, is this someone that has a good chance of getting better or not? And or what we've done a lot of work on is looking at, regardless of this one visit, is this someone that is going to keep coming back and keep having recurrences and keep having problems, or is this someone that's going to do really well and probably not need that? And I think some of the tools, like the Start Back, the Ospro Yellow Flag, some of these tools have come out to try to help predict that, because I think that's what people want to know. Do you think do you think we're ever going to get to that point? I just saw, I think on Twitter, a paper that just came out, and they had like several hundred predictors for outcomes for back pain, this huge individual person data analysis, and not a single thing was able to predict, reliably predict outcomes. And so do you think we'll ever get to the point where someone can walk in and we'll have a robust enough model to say, we know exactly what direction you're headed?
No, I think, we'll get to a point where we're better at it than what we're doing right now, I think. But at best, if we can identify 50% of the individuals, I think that's pretty fantastic. I think, what we're looking at, we're actually modeling a social determinants of health model right now. And I think that's going to be a way of measuring that at baseline and looking at how it actually alters recovery. And I think that's going to be an important piece. But I think there are, it's almost like predicting injury, right? Injury risk. There are so many dynamic factors that happen after the time that you actually measure to your endpoint, when what you're trying to answer, who they talked to, what they were told, who they saw first, what treatment they received, and how that merged with their expectations. All of these dynamic elements are really going to take a different type of measure to really figure that out. But I don't think we're ever going to get to the point where we're going to predict, like Logan's Run, right, where you can predict, you can change things on the fly, and I don't think that's going to happen.
You mentioned patient. We know patient expectation and belief is so powerful, and we talked earlier before Dan got on about the GROC and just how that is a great measure that captures change. And what if we simply made that question be a belief question? Like, do you believe you have the chance to get a very great deal better, versus do you believe you can get better at all? That the opposite of the scale. Like, how interesting to capture belief in just one question and expectation.
Yeah, so expectations is a great topic, and it's complicated, and I'm the first to admit I don't fully understand why it's so powerful as a predictor. And we're in a trial right now, and we just pulled the data to submit it to the funding source. And I looked at it, and the expectations, we use the modems, which is the 6-item question related to expectations with activities. It wasn't related to any other measure, not the pain catastrophizing scale, not pain intensity, nothing. And so I don't think we've completely figured out how to measure expectations yet the right way. If there is a way, then that should be an automatic, because that does seem to be driving a lot. But I think expectations is more complicated. And if we could really build a good scale that had expectations built out beyond what we're doing right now, I think it would be more telling. But I know there's a group out of Sweden that's looking at this for the hip, and I think, but there's a lot of work to do on that, I think.
Thanks for your time today. It is complicated. That was a loaded question.
I appreciate it.
Yeah, thanks, Chad. I'm out of ideas. I've learned everything I need to know now. It's good.
Hey Dan, congratulations on your New England Journal of Medicine paper.
Oh, thank you.
Smoking, man. That had to feel good.
Yes, it's good, but it comes with a lot of extra work, when you I mean, it's nice, but then you publish in other papers, nobody notices, and now it's like everybody wants to reach out, and there's questions, and let's do this and that, and it ends up, and I'm not even the primary author, so it ends up being lots of work, but I think it's good. It's brought a lot of visibility to our to PT, I think, and in general, so it's generating some good discussions. But thank you.
Yeah, well done.
Great. I'm gonna push stop the recording, and you guys can chat like normal.
I think the way that you code something too will make a difference, especially, almost all the studies we compare the one mean versus the other mean, the mean and the standard deviation versus the mean and the standard deviation. And we just finished a trial where we looked at steroid versus a proprietary injection to the knee, and there was no difference, repeated measures, GLM over time, when we looked at the means comparisons. But when we coded the groups as either improved or maintained, and this is OA of the knee, versus declined over time, there was a remarkable difference between the two groups, and significant difference across every outcome measure we looked at, all the KOOS measures, all the other measures, all the self-report measures, the Tegner, and all we did was change the way we coded it. So I think in many cases, to get to Dan's point, the way you look at it, if you get away from the mean and you start looking at maybe the extreme points, you might find a very different picture overall.
Yeah, it's interesting. We have to relook at, I know we just take a lot of these statistical approaches and what we've done for granted, kind of for granted. And I think as time evolves, there's newer and newer models and newer ways to look at things. And the things that we just sort of assume as this is the right way to do things, it never provides a full exact picture. It's just, this is the best approach. We're trying to analyze and capture the essence of something, but it's still a model that isn't perfect, and there's still a lot that's missing there. And so that's really interesting. I think you and I have been looking at this a lot, and I think there's a lot of interest in this as well, and is knowing who well, obviously we all want to know who. It'd be great if someone walked in and we could know whether they're getting better or they're getting, they're going to get better or they're going to get worse. Like, is this someone that has a good chance of getting better or not? And or what we've done a lot of work on is looking at, regardless of this one visit, is this someone that is going to keep coming back and keep having recurrences and keep having problems, or is this someone that's going to do really well and probably not need that? And I think some of the tools, like the Start Back, the OSPRO, Yellow Flag, some of these tools have come out to try to help predict that, because I think that's what people want to know. Do you think do you think we're ever going to get to that point? I just saw, I think on Twitter, a paper that just came out, and they had like several hundred predictors for outcomes for back pain, this huge individual person data analysis, and nothing, not a single thing was able to predict, reliably predict outcomes. And so do you think we'll ever get to the point where someone can walk in and we'll have a robust enough model to say, we know exactly what direction you're headed?
No, I think, we'll get to a point where we're better at it than what we're doing right now, I think. But at best, if we can identify 50% of the individuals, I think that's pretty fantastic. I think, what we're looking at, we're actually modeling a social determinants of health model right now. And I think that's going to be a way of measuring that at baseline and looking at how it actually alters recovery. And I think that's going to be an important piece. But I think there are, it's almost like predicting injury, right? Injury risk. There are so many dynamic factors that happen after the time that you actually measure to your endpoint when what you're trying to answer, who they talked to, what they were told, who they saw first, what treatment they received, and how that merged with their expectations. All of these dynamic elements are really going to take a different type of measure to really figure that out. But I don't think we're ever going to get to the point where we're going to predict, like Logan's Run, right, where you can predict, you can change things on the fly, and I don't think that's going to happen.
You mentioned patient. We know patient expectation belief is so powerful, and we talked earlier before Dan got on about the GROC and just how that is a great measure that captures change. And what if we simply made that question be a belief question? Like, do you believe you have the chance to get a very great deal better versus do you believe you can get better at all? That the opposite of the scale. Like, how interesting to capture belief in just one question and expectation.
Yeah, so expectations is a great topic, and it's complicated, and I'm the first to admit I don't fully understand why it's so powerful as a predictor. And we're in a trial right now, and we just pulled the data to submit it to the funding source, and I looked at it, and the expectations, we use the modems, which is the 6-item question related to expectations with activities. It wasn't related to any other measure, not the pain catastrophizing scale, not pain intensity, nothing. And so I don't think we've completely figured out how to measure expectations yet the right way. If there is a way, then that should be an automatic, because that does seem to be driving a lot. But I think expectations is more complicated. And if we could really build a good scale that had expectations built out beyond what we're doing right now, I think it would be more telling. But I know there's a group out of Sweden that's looking at this for the hip, and I think, but there's a lot of work to do on that, I think.
Thanks for your time today. It is complicated. That was a loaded question.
I appreciate it.
Yeah, thanks, Chad. I'm out of ideas. I've learned everything I need to know now. It's good.